The Conversational Flow, a KCAS podcast.
Hello, and welcome to the 10th episode of The Conversational Flow, an official podcast of KCAS Bioanalytical and Biomarker Services. KCAS is a bioanalytical CRO serving the pharmaceutical and biopharmaceutical industries for over 40 years. Unlike KCAS' other podcasts, the Weekly Bioanalysis, which features news and topics more generally associated with the world of bioanalysis, the Conversational Flow focuses more on the niche of flow cytometry and its role within the greater industry. My name is Adam Cotty. I've been in the flow cytometry space for over 15 years. I'm here with my co-host, Brian.
Thanks, Adam. My name is Brian Weil, and I've been in the flow cytometry space for over 13 years.
Brian and I are members of the growing leadership and scientific advisory team at KCAS. Either or both of us are available to answer any questions you may have regarding this podcast or any of KCAS services. While our KCAS headquarters are located in Kansas, with additional locations in Europe and a partner location in Australia, we're both here in Philadelphia, and Jeremy, our producer, is in Missouri, so we're truly all over the map. We're overjoyed to have you listening to our 10th episode. Yes, that's 10th episode. We made double digits. To be available virtually everywhere. Wherever you choose to find and play your podcast, you will likely find the Conversational Flow. We welcome all of you, whether you're joining us for the first time or if you're a regular listener to any of our other podcasts. Today's episode will be a review of the latest news and resources, and then a focus on a topic of our choosing, before discussing any feedback we've received from you. We're constantly looking for topics, and we'd be happy to discuss something that you want us to cover. So again, we're exhilarated to have you here, and we look forward to a fun episode today. To kick us off for episode number 10, Brian is going to go over the news and resources before diving into today's topic. Brian?
Thanks, Adam. We've definitely got some exciting news today. So just to start off with medical research news, the first item that we've got on the agenda is Cartesian Therapeutics, and they recently announced their positive results from their phase 2b trial in myasthenia gravis.
Yeah, so this is Descartes 08, which, essentially for those that aren't familiar, myasthenia gravis is a neuromuscular disease, so essentially causes skeletal muscle weakness. The body generates autoantibodies against several targets. One of the primary ones is the nicotinic acetylcholine receptors. And these are between nerve and muscle, and so basically blocks the impulses. And so what they're looking at doing, they're creating chimeric antigen receptor T cell therapy, CAR T. We've talked about many, many times. However, this is mRNA based, which I found really interesting. Everything that we've discussed previous has been DNA based. And so you may remember with COVID vaccines, for example, Pfizer, Moderna are mRNA based. And so what this does is there's some benefits. One of them is there's no preconditioning for chemo or preconditioning chemo that's needed, and it can be administered as outpatient. And so there's also no genomic integration, which is important. Very rare side effects with genomic integration that could happen, such as cancerous transformation. So with this, there is that risk has been eliminated. So one of the things, Brian, I was kind of curious about in your perspective, if you had the chance to read into it, is persistence, right? And so with mRNA, the thing is the signal will eventually diminish and, no longer cease, no longer exist. And so, what is the persistence of this therapy? Is it a one-time thing? Is it a multiple? What's your perspective?
It's interesting, right? And with mRNA cell therapies, my understanding is that once the cell has been modified, yes, the mRNA itself can be somewhat transient, but if there is a T cell that is persisting and it's got markers that it's expressing that are useful,
Mm-hmm.
that this type of immunity will then also persist either along with that specific T cell or as that T cell propagates because it has those properties. Is that your understanding as well?
I think so, at least for a period of time. I know initial studies with chimeric antigen receptor T cells who saw persistence out to 11 years and beyond. Uh, Not sure whether or not this would have something like that, but essentially the message may be that it's not necessary, right? So what the goal is essentially to reset the immune system so you're not creating these autoantibodies. And so if you're able to do that, and here what they're targeting is BCMA, so this is a B cell maturation antigen. You basically destroy that target type, then you're not producing those autoantibodies anymore.
Interesting. And then, you pair that with the FDA's recent just announcement. I guess it's not that recent anymore. It's November, October of last year, that they indicated that, all CAR T therapies that used a genetic factor to modify the CAR T cells should be investigated for potential cancer risk just on the mechanism of the drug there.
Hmm.
Um, you pair that with that, and all of a sudden the potential cancer causing thing eventually removes itself, which is interesting, right?
Yeah, and I think that's really one of the distinctions here when you're going into autoimmunity instead of cancer. There's always the risk with cancer that it starts again, right? And metastasizes. It's no longer dormant. Whereas with autoimmunity, and certainly with the therapies that are out there, that happens. There's a relapse, but I'd be curious to see what would happen specifically in this sort of paradigm.
That's interesting. We're going to have to find somebody from Cartesian to come on the show then and talk more about this, because now you've really piqued my interest to understand if that is really the silver bullet and then like the ideal way to treat autoimmune diseases.
Hmm.
Um, yeah.
Yeah, it is interesting, and a couple of other side pieces. As I was reading through, there's talk about the scale, how they evaluate patients with myasthenia gravis is an MGC, so myasthenia gravis composite, and so essentially just look at the various components, the indicators of disease and the severity, and there are 10 important functional areas that are affected, and they evaluate that and then report the final scale. And so that's why when you look at what the MGC score is at 3 months, and they're talking about 71% observed clinically meaningful over the 25% placebo, that's what they're talking about.
It's pretty significant, right? And myasthenia gravis is not a mild disease in a lot of cases, so that it can be pretty life altering. So for over 70% of subjects to see a clinically significant change is very meaningful.
And some of the things that they talk about were issues with the eye, drooping of the eye, muscle weakness, things of that nature, but also complications in swallowing and breathing. So to your point, this would be pretty serious complications.
That's right. And you think of autoimmune diseases in some cases as being less life-threatening or less acutely life-threatening than cancer. So, you'd really want that enhanced safety of exactly that mRNA type CAR T therapy.
Hmm.
Um, so, pair that enhanced safety profile along with this really high efficacy rate, and then you've got something, really potentially special here. So, yeah, we'll
Hmm.
definitely continue following this up. This news article that we linked here also contained a couple teasers about what's coming up next for Cartesian. So they've also got some lupus trials starting up, and I think they're looking at this for other indications as well.
Yep. Hmm.
So yeah, very exciting stuff.
Absolutely.
Yeah. All right. And then, we'll keep it going with the RNA train here, because the next one is around Beam Therapeutics. And that story is around the first patient that they've dosed in their alpha 1 antitrypsin deficiency, so AATD trial, so the Beam 302.
Yeah, so this is lipid nanoparticle technology. So just think of balls of lipid that carry a payload. And you were mentioning gene therapy. So they're actually looking to modify a point mutation. And what happens in this disease state is that because of this mutation, misfolded protein builds up within the cell and can cause toxicity. And it essentially drives liver and lung disease. It can cause early onset emphysema. And so not only we have issues with it being intracellular, reduces the inhibition of proteases, which cause destruction. So, excuse me, the therapy here reduces inhibition of the protease and then allows for amelioration of the disease state. And so right now there's currently no curative treatments. And one of the only things I saw was that there's an IV AAT protein replacement option. So not necessarily something that cures it, and essentially just aids in being more functional, from what my understanding was there.
Yeah, that's exactly right. So nowhere else to turn to, and then you've got this therapy. So I mentioned RNA, and the reason I said that is it's using base editing,
Mm-hmm.
and this base editing will usually use an RNA guide strand to dictate what its target is.
Mm-hmm.
Um, so definitely an interesting and very cutting edge therapy there. So you've got everything that's been in the news for at least the past like 5 years in terms of medical developments, right? You've got base editing, which is usually some version of CRISPR or something very similar to CRISPR. You've got RNA, you've got lipid nanoparticles, organ targeting. So a lot of very interesting things there,
Bringing all the technologies together, right?
right? Yeah, and the hope, as you say, is to correct this one mutation, and then also the hope is that some of these base editing reagents will be significantly safer than what we've seen with some of the CRISPR reagents or zinc finger nucleases. In general, very excellent reagents that can do some great things. Generally require ex vivo application because they do have the possibility for off-target editing.
Mm-hmm.
So this should be a safer way to edit without making potential significant DNA mutations that, again, could lead to an oncogenic risk there.
Mm-hmm. Yeah, so excited to see what the next steps hold there. It does seem to have broad appeal, and one of the other benefits here is that it doesn't cause double-stranded DNA breaks, and so it just makes it, like you said, safer option.
Yeah, indeed. And with both of these things, now we're looking again at CAR Ts. We're looking at autoimmune that we've talked about a few times now. We're looking, at base editing and lipid nanoparticles. So all talking about sort of new technologies as they're being developed. So that's a good time to maybe shift over to investment news and talk about some. I think we've got this time a company closing in on its first Series A, so an early stage funding round, and then
Mm-hmm.
also one that's sort of progressed through a couple different funding rounds and is now going public.
Mm-hmm.
So the first one is around Augustine Therapeutics that just raised a little bit over $18 million in a Series A.
Yeah, so the primary target here is HDAC6, so histone deacetylase 6. And essentially, what is histone deacetylase? Well, just to take a step back, in the simplistic sense, DNA wraps around histones, right? It's for organization of the DNA in the nucleus. And so modifications to the histones by adding or removing things such as acetylase allows for regulation of transcription. And so you can think of it as either turning on or turning off a gene. In this situation, when this gene is upregulated in the nucleus, it negatively impacts transcription and leads to disease state. So removes the acetylase. And so what this therapy does is it's a inhibitor, right? And so it will prevent that gene from basically removing that acetylase. Additionally, in the cytoplasm, it has other functions, and so aggregate formation, transport of proteins within the cytoplasm, as well as neurotransmitter release of non-histone proteins. And so all of these, make it a attractive target here. And so giving a little bit of background too, as far as HDACs are, when I was doing protein expression, we were doing recombinant protein transiently, we would actually use sodium butyrate, which essentially is an HDAC inhibitor. And what that does was that allowed the genes to stay on during the process of expression, and we were getting higher levels of protein yield there.
Interesting. And I'm sure basically the difference there is a sledgehammer to be used in cell culture that can get through cell membranes pretty easily and things like that, as opposed to this needs to be ideally a little bit more targeted or it looks like brain penetrant in this case.
Well, it looked like that was going to be the next phase of it. The initial phase wasn't, but I might be missing that.
Oh, you're right. Yeah, no, it says the first one will not be, and then yes, next generation versions of this will be brain penetrant. So interesting. Yeah, it's interesting in terms of the type of companies that we see getting Series A funding, and also how much. So with this company, it's a relatively small company, and it's getting funding from a couple of interesting parties. So one interesting party is the CMT Research Foundation. So basically, the patient group that would stand to benefit most from a therapy targeting HDAC is contributing to companies that are funding a commercial cure. So I found that part interesting. But then also, some of the other ones are, of course, your standard venture capital, but also then Eli Lilly, which is another interesting trend. So a couple of pharma companies now have pretty large venture arms that are selecting these smaller groups to be very nimble and do discovery and early phase clinical research with the thought of potentially acquiring them once they de-risk some of these very new targets or new platform targets there. So interesting from that standpoint that the companies that are really getting started now have these sort of moonshot type ideas. And then also interesting that these patient groups, in a lot of cases, are getting more and more organized and better funded and acting like small venture companies or small sort of pharma companies targeted at a disease, which I think is a very effective outcome. Requires patients and their families to become sort of pharma executives, but is likely the most efficient way to direct these sorts of research funds.
Yeah, I mean, the movement of funds drives a lot of things, as we know, in all facets of life. Plus or minus. I mean, it is the world we live in, right? And so if you have it, you're able to get it. You're able to push and get the therapies moving along that you need to do. I won't go into the whole financial news, so to speak. But yeah, I agree with you. I think that's a really interesting development, and I think bodes well for identifying all sorts of different therapies that might not have otherwise got funding.
Agreed. And then along that bent, sort of farther along the pathway. So usually there's Series A, and then generally a number of series. I think I've seen out to like Series F or something like this before. And then at some point, basically companies will just go public. So the second investment story I've got is Alumis, that is a biotech company in California that just did its initial public offering. And during that, it raised an additional $250 million of capital.
Yeah, it was pretty high. Although it was on the lower end of what they were intending, it was still the third largest of its kind this year. And so what are we talking about here? Looking at targeting autoimmune diseases. And so very much a theme of many of the things we've talked about lately, the last couple episodes, and even today. And again, too, the target, TYK2. And so we mentioned that back on episode 8. Here, their therapy is ESK1, which is testing plaque psoriasis and lupus, among others, and looking at TYK2 as well for neuroinflammatory conditions. One of the things that I kind of wanted to learn more about when researching this was the scale that they evaluate psoriasis on. And so it's the PASI scale, PASI. And it stands for Psoriasis Area and Severity Score. Here, the article talked about the 75 being the benchmark, and the PASI 75. And so what that is a 75% reduction over baseline before that was established at treatment, before treatment, I should say. And so it looks at the size and severity of the lesions, and then 12 weeks later, compare against placebo. And the trial met its primary and key secondary efficacy endpoints. So just something new for me. It really hadn't really done much investigation into psoriasis scales and how those things are measured. And I know we've talked about TYK2, so it was really kind of focusing on what kind of methods were there.
Yeah. Anything interesting you found in your read-up on methods for TYK2?
As I said, focused less about TYK2. We did that back in episode 8, but I always fall back to with TYK2 here talking about intracellular flow cytometry methods for evaluation.
Sure. Yeah.
So, you didn't really drive too far from home on that one.
Yeah, makes sense. Yeah, I mean, when what we've got is a hammer, then everything starts looking like nails. So, yes, absolutely. Flow cytometry involved in all of these things. And yeah, it's interesting too about all of these, because I think everything that we have talked about has been a relatively rare indication, right? Where you're looking for patients with very severe versions of diseases. You're looking for relatively small population sizes. You're looking for things sort of on the extreme end of a scale that it gets debilitating for what would otherwise be a manageable disease type. And for those, it's just to segue into the main portion of our podcast here on multi-site standardization. You really need to significantly increase the size of the population you're looking at, because if you think on the order of a city, let's say there are 10 million people in there, because math is hard, and you've got something that's impacting 0.1 or 0.2%. And then of that 0.1 or 0.2%, only a few of those patients will actually join the trials. It gets difficult just to find the sheer number of people that you need for a clinical trial.
Yeah, it's a great segue. I mean, so you can't just focus in one or two regions. You've really got to broaden your scope to be able to get the appropriate population.
Yep. And then the question is, how do you make sure that you can test in the same way and get some sort of standardized outcome, right? Like you're talking about these scales that you're using in between each one. So how in the laboratory make sure those scales are the same?
Well, to your point, I mean, you put out a paper that reviews 2,559 individuals over 4 years.
That's it. In terms of KCAS news, of course, we're sending our own Natalie Carroll out to Australia to start some of the standardization process on our end. So she'll help with the standardization of the Cytec Aurora systems that we announced that we'll be putting in both a Melbourne partner laboratory, Crux Biolabs, as well as our Lyon facility.
Yeah, go Natalie. Really excited to see this come together. I will say that we weren't disappointed in the conversation, having mentioned kangaroos from our Australian counterparts. It is winter down there for them. I'm not sure exactly what that means, the temperature. I didn't ask the last time. Are you aware? How cold is it down there?
I mean, it's a desert, so yeah, anything's possible, I guess.
Maybe not so cold then.
Yeah.
So, but yeah, I mean, also too, like you mentioned, we're getting those side techs up and running there, and it's a big milestone. And Natalie is fantastically suited to that. Definitely has a lot of experience, and it will be great to guide the team and make sure that there's harmonization between the sites.
That's it. And so the paper that we chose to talk about today sort of dives into that a little bit as well.
Yeah, so the paper of the month, standardization procedure for flow cytometry data, harmonization and prospective multi-center studies. It's published as scientific reports. So the impact factor is 3.8, which is a rather nice, rather strong impact factor. As I mentioned, in the teaser, they evaluated 2,559 individuals, fresh samples, 4 years. And what they were looking at was how they could harmonize across multiple sites, multiple instruments, and still get reliable data. And in this, they're looking at frequencies, MFIs, making sure that they're consistent from sample to sample, run to run. And it's really interesting that normally when we talk about harmonization, we're thinking about taking like for like machines and making sure that across the different sites they're all performing as expected. And so, for example, we've got two Fortessa's 5 laser units here in the U.S., and then we've got two of the same over in Lyon. And now we're doing the same thing with the SciTechs. We've got two SciTechs in Philadelphia. We just had two sent over to Lyon, and we've got two over in Australia as well. And what we're doing is trying to make the harmonization as easy as possible. This paper didn't do that. Frankly, they tried to make it as difficult as possible. At one point, even they were messing around with the voltages, the PMT settings, to see if their process was robust enough that if somebody did make a mistake like that, that they would be able to account for it.
Gosh, taking something that's already hard and making it harder.
It's a great way to make it robust, right?
Yeah, that's it. Can you break it?
So I would say, Brian, in reading this paper, obviously it talks about a lot of the things that we do for harmonization. Even when we do inter-instrument, we do inter-analyst, considerations that we got to make the assay as robust and precise as possible. What was something that stuck out to you?
The biggest thing that I think stuck out to me was, even though, yes, they use different instruments and they tried to make it as difficult as possible, because they used fluorescent standards, so the 8-peak QC beads, just having that sort of calibration range allowed them to do a lot of what they did. Like without that piece of it, nothing else that they did would have been possible from what I took away.
Right. And so those 8-peak beads are for intra-site. So within the site, they're using that to standardize. And then across the different sites, they were using VersaComp capture beads to standardize the instruments and make sure that they're obtaining similar MFIs across the instruments on identical samples. I think for me, really, the way that you start something like this, you can talk about the instruments all you want. But if you don't share the SOPs ahead of time and make sure that the prep and the training is harmonized, you're already starting behind the 8 ball. And this is even discounting all the different machines they used. But you've got to make sure that all of that is done ahead of time. There's a lot of legwork that goes into a setup before you even consider the machine. And so, some of the things that they mentioned as far as minimizing harmonization, you want to have the same equipment if possible. Well, this is what groups do, I should say, to minimize the impact when you're trying to harmonize the differences of harmonizing. Getting same equipment, using frozen samples, And then they mention about inter-instrument comparability studies on small sample sets. Just try ways to try to navigate here.
Yeah. And, the other thing that I think they did was they used the Duraclone panels from Becky
Yes.
Coulter. How significant do you think that was in terms of the harmonization?
And so let's talk about what Duraclone is. They're dried antibody panels, right? So the master mixes are made, they're dried down, and then they're reconstituted when needed so that one, you're reducing handling, two, errors in master mix are reduced, and you're extending stability. I think all of those they really lend itself to making sure that you have consistency in that part of the process. And so, yes, I certainly think that helped. You're not incurring deviations because somebody didn't add an antibody, for example.
Sure. And, in theory, with using consistent lots, you're minimizing variation. I wouldn't expect too much variation from master mix, but again, it's one of those things that helps consistently.
So they did actually have some variation. They used 3 lots of the Duraclone over the course of the study, and did note that let's see, uh, they ended up having to add a new script, Python script, to be able to isolate the variation between the Duraclone lots. It was just one of the several things. So a big part of this paper is how they process the data, and really a lot of work obviously went into it. One, because they start off with our script. Let me see if I can pull up where I've got the entire process here. So let's see, the analysis work stream, they harmonized the instruments. Then they normalized within the sites using 8 peak beads, targeting less than 5% difference. Perform manual compensation, automated the data analysis, and then they did intra-site correction off of the 8 peak beads. This is using Python, and then inter-site correction off of Versacomp for Python as well. And so with that, it was really interesting to see how then, as they ran through and got more data, they were able to then update their scripts so that they identified different areas of variation. For Let's see, one of the interesting notes, though, in doing so, right, you don't want to essentially bias your data, especially unknowingly, but they had mentioned about the CD19 MFI between diseases in all the centers. So this just wasn't one disease. They had several different diseases that they were getting samples for the study, and essentially looked at the CD19 MFI and noted that even when they had updated to remove different sources of variation that were machine based, they did still see the biological differences of the CD19 MFI, demonstrating that they were modifying it appropriately and taking out the correct errors, so to speak.
It is interesting. And then what do you think about using frozen controls versus a synthetic control or a fixed control like a Strect?
So, one other thing that I noted, I should say I dug into a little bit more because it wasn't as much of a strong area for myself in understanding machine learning. The differences between supervised and unsupervised automated gating. They chose supervised. And so what the difference is here, for those that don't know, supervised, you input information, you input the data, and you input what the desired output is. And then the machine learns what is it's supposed to spit out. And then the next time it analyzes, it has that essentially a template. Unsupervised is just feeding it all of the data, not telling it how to do the analysis, essentially, not what the goal is. And then what it does is it looks for patterns without guidance, which is certainly very interesting as well. We get questions about stuff like that all the time. We're looking for patterns in this marker. Are you seeing it, or so on and so forth? Based on cell type, things of that nature.
Yeah, and I think the supervised versus unsupervised automated gating is extremely interesting, right? Like, how much do you trust software to go and make those decisions for you? Will it come out with correlations that are real or correlations that are potentially caused by something else? Whereas if you have a trained observer, they're ideally making those decisions on what to supervise based on what is biologically meaningful there.
You're right, and I look at it, at least from my perspective, as different parts of a process. So when you're doing your initial gating, you're doing your initial analysis, you want to have a set gating philosophy, and that's what we do when we do validations and qualifications. Is we identify what the gating scheme is going to be, and then we stick to it. Now, obviously, you can move gates depending on what kind of controls you're using and whether or not you're basing it off of your initial sample, so on and so forth. But it remains the same, that you have a standard gating strategy. And so that's where I see that supervised coming in. To your point about the unsupervised, it's like a mining expedition, right? You're trying to see if there is something in the data that maybe you're not picking up. And so you probably will do it in parallel, maybe do the supervised one way, do the unsupervised another way, see what comes out, just to really get a good handle on what is going on in your data.
Yeah. Our colleague Todd would likely prefer a fishing expedition in terms of analogies there. And yeah, sometimes the unsupervised can bring you, that one fish that you hadn't been able to find previously. And other times it'll scoop up a tire on the bottom. So, you have what you get.
Yeah, those tires are never fun.
Indeed. And one thing that I was asking about was around controls. And you mentioned that in this paper they were using frozen PBMC controls, I think.
So this was the thing I was trying to dig up. Initially, I think the actual study is on fresh samples, if I read correctly. But then I think when they talked about using the same samples, you're not going to be able to use the same samples across different sites. And so if that were the case, you would generally use something like a frozen or Streck control.
Okay. And that was going to be my question. Like, how would you, because this had to have been just an obscene number of runs, right? If you think about all these different samples, thousands of samples, if they're coming in one or two at a time and you're running them on fresh samples, that means you'd need that number of controls. So all of a sudden, PBMCs become potentially non-viable, and you need something like Streck to run, with each sample as it goes through, or beads for that matter, of course. So.
Yeah, and in this case, I think the majority were beads, but you're right. I mean, when you're running your samples, you want in a case where maybe you don't have a Duraclone, you're making the master mix every time, and you want to ensure that you've got all of your markers in there. A great way to do that is either PBMC or Streck control, where you can basically stain it with the same master mix that you're staining the sample with. And so sometimes a marker may be really almost not existent on a patient sample that you had seen when you had done your validation or your qualification. And so having something that always has that marker gives you that confidence that you're doing it properly.
That's it. Yeah, and then maybe that's a good time to jump into, overall just philosophical instrument-to-instrument comparisons, right?
Yes. And so, again, here, the instrument to instrument comparison, they are using different instruments, right? And so what our topic is, what are you talking about when you're talking about a comparison? Essentially, you want to align the performance to ensure that you're getting consistent data, comparable results out of both instruments. And so you would run the same samples on both instruments, assuming you're talking about two instruments here. That's what we do for our Cytex or for Tessas. And then you evaluate those same samples in replicates to determine what what your percent CVs are, and the differences from sample to sample there.
Right. And, between instrument to instrument, things that can be different. With different instruments, you may have different types of lasers. You may have a different path for the laser to actually get to the detector. You can have different detectors. You can have different filters in front of those detectors. You can have different sensitivities of detectors and tunable sensitivities.
Different laser power. The machines may have been maintained differently. When the machines are set up, the filtration may be slightly different. Obviously, try to make sure that everything is done the same. But then, even outside of the instruments themselves, things that could impact and create variability between the output between instruments. You get your reagents, making sure that they're the same or like for like, difference in operators, making sure that your staff is trained. So if you have different staff that run different machines, then all of a sudden you're adding another level of variability there. And then the way that samples are treated.
Yeah, and then with regards to that instrument to instrument variability, in the past couple of years, what do you think the trend has been in terms of, is the variability between instruments increasing, decreasing, staying the same?
So within same instruments, I definitely think that it's becoming less variable. We would do inter-instrument between older instruments, and there were more markers that would fail. Whereas now, inter-instrument between some of our new ones, the Cytex, fewer. There are many fewer failures there, and so it just speaks to improved optics, automated calibration, quality control in manufacturing, the design of the instruments themselves, whether it's modular or not. It just all basically owes to making it so that one machine to another machine is that much more similar.
Okay. So basically, the components of the machines are now much more common. Like, when cytometers first came out, lasers in general were quite fancy, right? Like, yes, we talked about the laser pointers being used for cytometer last time. But, now the, 50 to 100 milliwatt laser is relatively commonplace, and, manufactured in a very controllable format. So there's minimal differences between those things. And then
Mm-hmm.
also with the detectors, again, I keep going back to photodiodes because I think that they're just wonderful. But there's much, much less variability between those photodiodes than there are between photomultiplier tubes.
Mm-hmm. Right. And so then taking that a step further, what are some of your thoughts as far as what can be done to minimize the impact of instrument differences?
In terms of minimizing impact, is definitely making sure, as you said, starting out to do your voltrations early and make sure you do all your standardization up front on the instruments before you start using them. Because, of course, if you start some assays and then standardize your instruments and basically change the settings, then you'll need to come back afterwards and change settings on those assays that you had already established. So that's always a critical thing, just upfront preparation.
Yeah, absolutely. It's amazing how, with this sort of thing, it's the smallest change that really can cause an impact. You really have to be observant in your process, making sure that it's moving properly.
Yeah,
And
that's it.
so,
And then, on top of that, I'd say it's the increasing prevalence of really good reference standards. So you mentioned the 8-peak beads and the VersaComp beads from this paper, but there's just been a proliferation. That ecosystem of beads and fluorescence standards really didn't exist, even 20 years ago, in the same way that it exists now.
yeah, throwing the slingshot in there as well. That those type of controls, very custom, but certainly helps to maintain processes there, visibility, I should say, on your output and making sure it's looking as the way you need it to.
Yeah. And hopefully, what all of this will combine to mean is basically we get a lot more papers like the one that we just reviewed and a lot more opportunities for multi site trials.
Yeah, I see it too as a reduction in variability, a more simplified work stream, hopefully easier harmonization, and getting more dependable cross-site data. Years and years ago, it just was very difficult. I mean, it certainly could be done. There's a lot of work that needed to go into it. It's not to say that it is easy now, but hopefully trending in that direction. And again, just hammering home the point that it still requires the processes being nailed down so that it can be done successfully.
Sure. If you've got nothing to standardize, then standards will not help.
For sure.
Yeah. All right. And, that's, I guess, most of what we want to cover today. Anything else to add on instrument standardization or instrument-to-instrument comparisons?
I think that we are continuing to evaluate how we go about doing it with the industry constantly evolving. It's somewhat of a moving target. You always want to make sure that you're getting the best data that you possibly can, and the only way to do that is to keep on top of your instrumentation and your processes. And so what we do now is really just the basis for most likely a broader effort in the future, a more robust effort in the future, even based on newer information as it comes out.
Yeah, which is a good segue, of course, into our feedback request. So appreciate all the feedback we've received so far on favorite types of automation from our episode 9. For this episode, we really want to ask the audience overall, what is the most important guidance question that could be answered in an update or extension to the H62 documentation to make flow cytometry more standardized?
It's a good question. I like that.
Yeah, so H62 is out there, and people are referring to it, as often as possible. But it always has holes, right? Like, it doesn't say much at all about spectral flow. It doesn't say much. It says some about how to run a large multi-site trial, but definitely doesn't cover what types of bridging experiments are required, how to carry out some of these things. So which part of this would you be most interested in seeing, and how would that impact sort of what you're doing today if there was additional guidance there?
I really felt like you were going to go through all the questions and then nobody was going to be able to send some in, You didn't say RO assays. That's one that I certainly would like to see more information in there on.
Yeah, absolutely. So looking forward to feedback there. Please do send us any questions. You can either email us directly or add comments to anywhere that you get this podcast, and we will at some point see them. All right. And with that, I think we can, go to the end stage of our podcast here. So, towards that note, you mentioned earlier that your car washing went well. What are some of your other favorite summer water activities there?
Well, I will say that was definitely a water activity, not just because I was washing the car, but I was sweating profusely because it's so hot and humid in Philadelphia, in the Philly region yesterday. But water activities, there's so many things. I always loved swimming growing up. We had an above ground pool used to be in. I like to think of it like practically every day when I was a kid, but my parents probably like, oh, you were there a couple of days and then we just closed it up. And I don't even know why we bothered putting that thing up for you guys, but I don't know why it just made my parents sound like really horrible people, but they're not. I love you, Mom and Dad. So with that, also canoeing, whitewater rafting, done both of those. Went down Colorado River when I was camping the Continental Divide, hiking the Continental Divide, I should say. And so really enjoyed doing that. How about yourself?
Yeah, I'll add kayaking in there. Definitely like whitewater rafting. Kids aren't quite old enough yet. We went over some very, very small rapids. Like, I don't think they were even quite class 1 rapids in a kayak. And my 5 and 7-year-old were like, "Oh my goodness, this is the best thing ever!" And I was trying to explain that when they're a little bit bigger, we'll take them on a whitewater raft. But I wanted to make sure that they were big enough that I could like grab them back into the raft if they fell out.
I just see go-go gadget arms.
Right?
Yeah, that's awesome.
So
And then, so I think the other thing you had on there was summer food.
yeah, I feel like you need a good stew in the winter, but stews don't really fit the bill for summer.
Mm-hmm.
I always go for like a pasta primavera.
Oh, there you go. I had never thought about that as like a summer food.
Yeah.
Now, I did try something recently. So, when my daughter and I were out at Sea Isle, we went to the farmer's market and they had jams, right? And I've never really been a huge jam person, which first, hold on, let me take a segue, Brian. Now, if you make a peanut butter and jelly sandwich, what kind of jelly do you put on that sandwich?
I mean, I would say for me, 90% of the time, strawberry.
Oh, no,
No?
not straight. It's got to be grape, man.
Yeah,
Ah,
that
see,
is the other
this is
comment,
the
right? Like,
struggle.
yeah, when you buy the frozen PB&Js, I guess that's got to be the most standard. The Uncrustables or whatnot, because
They
they
make
make those
frozen
previously.
ones?
Oh yeah, they're frozen right now. And then you can basically take them out, and as long as you wait 20 minutes, then they're ready to go. It's a pre-made PB&J.
I have
Um,
never heard of those before.
so for camps, it is the thing to do. So you have all these things frozen. You take one or two out and stick it in their lunchbox. It's an ice pack in the beginning of the day, and then it's their lunch the rest of the day.
Hmm.
Yeah,
That's pretty cool.
wonderful.
The reason I asked about that was just because at home it's always been a bone of contention, strawberry versus grape, and I've always been a grape person my whole life. But anyway, so I'll get back to my story. Sea Isle Farmers Market. We come upon, what was it? Bacon jalapeno jam, right? And they mention all the different things that people have been trying it on. And we tried this a couple of years ago, and my daughter had the great idea of putting it on a hot dog, which I was kind of dubious about. Like,
Huh.
I don't know.
Yeah.
It tasted delicious. All right. So they're saying, oh, you could put it on meatloaf. You could do it on all sorts of things. So I'm grilling up burgers, and
Who was telling you this? The person that was selling the jam, or the
yes,
person, or your family that was eating the jam?
it was the person selling it, just giving us
Yeah.
different ideas, right?
There. Right.
So, anyways, I'm cooking up some hamburgers, and I said to my daughter, I was like, "Liz, what do you think? Should we put some jalapeno bacon jam on the burger?" She said, "Oh yeah, let's do it." And I definitely would put a healthy serving of it on. Oh my goodness, it was absolutely delicious. Like just the flavor, like the little bit of sweetness, but then you get the bacon and you get the jalapenos in there, and you put a piece of cheese over it, and it's so good. And then I followed that up the next day. I made a sausage, egg, and cheese sandwich on a bagel and put bacon jam on that. And again, it was knock my socks off. So highly recommend jalapeno bacon jam, I think is what it's called.
Okay. On my list. Excellent. All right. Well,
You got any
appreciate it.
interesting condiments on your side?
I'm a huge fan of the sweet chili sauce, but then also the I think it's called yum yum sauce. You
Yes.
generally get it at Japanese restaurants, and yeah, it's phenomenal. And also, you can put it on pretty much anything, right?
Well named. Yeah.
Yeah. All right, so I think that that does it for us for today. So please do log in next time and listen to us for episode 11. In August, we'll be talking about automation in flow cytometry, and ideally, we'll have a special guest to help talk about that. So
Yeah,
thank
very
you
nice.
for listening, and we'll talk to you later.
Very nice, and congrats to us on 10 episodes. We reached double digits, so
We did it.
big milestone.
Yeah, absolutely.
Thanks, everyone. Take care.
Thank you.